Okay, so we're going to start off with prevalence. So that's what we're going to cover now. I think most of you probably know this. I think we'd have it drilled into us all the time. But we do know that if diabetes was a country, it would be the world's third largest country. So that's pretty high, isn't it? Pretty scary. So this is the prevalence here. There's 415 million people in the world that have got it, that we know of. And then there's another 46.5% that are undiagnosed, which is a little bit scary, isn't it? So if you think about that, that's probably half of us in here that don't know we've got diabetes. So if you think of that, it's a bit scary. 1 in 7 births have now got gestational diabetes. Are you finding that in your practice, that you're seeing people more and more? They reckon that low middle income earners are the main people with diabetes. So that's good for us, isn't it? And children with type 2 diabetes, there's 542,000 that we know of. Every 6 seconds, a person dies from diabetes. So that's a little bit scary. This sort of explains how Australia looks in here. So if we look at Australia, we've got 1.7 million Australians with diabetes. So it's rather a lot. 1.2 million are diagnosed and 500,000 undiagnosed. And in the past 12 months, we've had 100,492 new registrations. That's a lot, isn't it? And if you think about it, if we've got a lot of people that aren't diagnosed, we're doubling that figure, really. Do you routinely do screening in general practice? Because I know that we used to have the 40 to 49-year-old health check. Is that taken up much by people? It is? Some practices, some not so? Yeah. It's hard to get that age group to come, isn't it? Okay. So what's the burden and the cost? We know it's really expensive. And we know that it impacts not just the person with diabetes, but the person looking after them. So there's a whole burden of care there, isn't there? So we do know that there's a family member or carer who lives with diabetes in a support role. So there's about 2.4 million Australians that are affected by diabetes. And that's an estimate. It could be higher. The total annual cost of diabetes in Australia is estimated to be about 14.6 billion. So a little bit expensive. And 12% of the global health expenditure is spent on diabetes. And if we do it in US dollars, because everything gets done in US dollars, it's $673 billion. It's a lot of money in the world, isn't it, going towards diabetes? Did you know that? A nod, a shake. It's expensive, isn't it? Okay, I'm now going to draw on the whiteboard. So can you all see the whiteboard? Okay, I don't draw well, I'm not Picasso, and it's very early in the morning. So don't expect miracles. And if I lose my glasses, because I need them to see, and then I put them down, you've all got to tell me where I've put them. Okay? All right. So, I'm going to draw for you what is diabetes, so that you remember, okay? So, and it's not drawn to scale or anything like that. This is your pancreas. And the pancreas does lots of things, but it's the beta cells in the pancreas which produce insulin. This is your liver. And your liver's a big storage depot. It either stores glucose or it puts glucose in your bloodstream, depending on what you need at that time. Yeah? Then your bloodstream is your transport system. The bloodstream carries the glucose around the body. So if your blood glucose is high, it's high from your head to your toes. And if it's in the normal range, it's in the normal range from your head to your toes. Your muscles are the biggest users of glucose in the body. And on your muscle cells, you have what we call insulin receptors. So, what happens in the body when there's no food involved is that your pancreas will drip, drip, drip insulin, and your liver will drip, drip, drip glucose. And that will maintain your blood glucose between 3.5 to 5. Sometimes you need a bit more insulin, sometimes you need a bit more glucose. But it maintains it. When you eat carbohydrates, they get digested, and glucose enters your bloodstream. That turns off the liver, so the liver stops putting glucose in your bloodstream, and it makes the pancreas produce more insulin to cover those carbohydrates. Within 2 hours, you should have used or stored that glucose, and the drip, drip, drip will start again. Make sense? Okay, so you eat your carbohydrates, they get digested, glucose enters your bloodstream. Pancreas, in response to that, produces insulin. Insulin enters the bloodstream and marries the glucose. It's a marriage made in heaven because it lasts about half an hour. Best marriage in the world. Now, say this muscle cell here needs some energy. The insulin will leave the bloodstream and attach to the insulin receptor, a bit like a key in a keyhole. That opens the door so that the glucose can go into that muscle and give it energy. Without the key opening the door, the glucose will stay in the bloodstream. Make sense so far? Okay, so in a 2-hour period, if you're running a marathon, you're going to use all that glucose up. If you're sitting on your bum watching telly, you're not going to use that very much at all. So at the end of that 2 hours, some of the excess glucose will be stored in your liver for that drip, 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 and any more excess glucose gets turned into fat, which goes across our tummy, which we all hate. Make sense? So you need insulin to use glucose for energy, or to store glucose in the liver, or to store glucose as fat. But insulin's job is to bring the blood glucose back to target. Make sense? Okay, there's 3 types of diabetes. There's type 1 diabetes, which is an autoimmune condition. So there's a trigger. It triggers the body's autoimmune system to attack and destroy the beta cells. You don't make insulin, you need insulin injections to keep you alive. Yeah? There's gestational diabetes, or diabetes of pregnancy. That occurs because when you're pregnant, your body has to make 4 to 5 times more insulin than normal because you're growing a baby, and the hormones you produce when you're pregnant cause insulin resistance. Usually when you've had the baby, the diabetes will go away, but you're more at risk of going on to develop type 2. What we see in general practice, most of the time, would you agree, is type 2. So type 2 is characterized by, on diagnosis, only about 50% of the beta cells are working. They haven't been destroyed like type 1. They've actually worked too hard. They've now taken their bat and ball and they're not going to play anymore. Okay? You also get insulin resistance. So what that means is, you eat your carbohydrates, they get digested, glucose enters your bloodstream. And the pancreas cannot make enough insulin to attach to all the glucose. So you'll have some glucose sitting in the bloodstream, not able to do anything. Say this muscle cell here wants some energy. You find a glucose that's got insulin attached. The insulin tries to attach to the insulin receptor, but it can't. You know when there's a change in weather and you try and open your front door and the key doesn't work? And you've got to put WD-40 into the keyhole to make it work? If life was simple, we could put WD-40 here. But we can't. So, because the glucose can't get across to here, the muscle sends a message to the brain. It says, "Oi, I need some energy." And the brain says, "I know what the problem is." And it pours some of that stored glucose into the bloodstream, actually making the whole thing worse. So that's why people can wake up in the morning and have elevated blood glucose levels and they say, "But I haven't eaten anything. I don't understand." And it's because overnight the liver's been pumping glucose into the bloodstream. Does that make sense? Told you it wasn't a good picture. Okay, I'm going back up here now. Oh, left this down here. You meant to tell me that. It's got to be your fault, it's not mine. Yeah, that's all right then. So what this picture shows you is that the beta cell function over time will become less and less and less. So type 2 diabetes is a progressive disease. And over time, you'll have 50%, 40%, 30%, 20% function of your beta cells. So you'll need more help with medications and things. Does that make sense? Okay. So, it's a chronic disease. You've either got it or you haven't. It's a bit like being pregnant. You either are or you're not. You can't be a little bit. So you know the patients will come and say, "I've got a little bit of sugar." Doesn't really work. So what I try and explain to my patients is, what the aims of the treatment are. So what we're trying to achieve. What we're trying to achieve is to keep them well. Because if we don't keep them well, there's no point, is there? Early detection and prevention of complications. So that's what we're trying to prevent. So teaching them about the screening that they need to do to help prevent the complications. We want to aim for HbA1c of less than 7%, and we want the blood glucose levels to be between 4 to 6 fasting and between 4 to 8 2 hours after a meal. Do you all agree with that? Okay. I don't like this slide, so I'm going to draw you a picture. So, all that slide is really showing is the progression that you go through to go onto medications. Now you have to remind me. I'll put that there, and my glasses, right? Okay. When you're first diagnosed with type 2 diabetes, you start off on diet and exercise. And if we can maintain your HbA1c at less than 7 and your blood glucose levels within that range, we're happy. As your HbA1c goes up and your blood glucose levels go up, we put you on metformin. That's the drug of choice to start off with. Metformin is an insulin sensitizer. It helps your body utilize the insulin that it makes itself. When your HbA1c starts to go up and your blood glucose levels start to go up, you usually go onto an insulin secretagogue. So that's your sulfonylureas like diamycron and things like that. And that helps the pancreas to make insulin. Then there's a whole suite of medications now, aren't there? There's your Forxigas and your Januvias and the Byettas. So there's a whole suite. Some of them slow your digestion down, and some of them get excreted through the kidneys. And then after that, we have insulin. So this whole thing could take 1 year, 5 years, 10 years, 15 years, 20 years. But people will progress through those stages. It's important to let them know that and then tell them what the aims of the treatment are, which is to keep them well, keep their HbA1c at less than 7, and keep those blood glucose levels within target. Does that make sense? That slide's a bit busy for me. Thank you. Did well there. Okay. So, how do we check to make sure that everything's under control? So the HbA1c tells us what's happened the previous 3 months. It tells us what the control's been like for the last 3 months. Would you agree with that? So it's good to tell you what's the average control is, but it doesn't tell you about the bits in between, how high you go, how low you go. It just tells you the average. So you could be ping-ponging, going bang, 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 and the average might be 7. Or you could be going along really well, and the average might be 7. You just need to know what's happening in between. So blood glucose levels are really important because they tell you the whole picture. They tell you about the patterns and trends, and they tell you what's happening right now at this point. Would you agree? So HbA1c is important, and that's been proved in a lot of the research that's around. And we know that with every 1% rise in HbA1c, we increase the risk of complications by 35%. So conversely, if we lower the HbA1c, we're reducing the risk of complications. That makes sense, doesn't it? So we want that HbA1c to be 7 or below because that reduces the risk of complications. And obviously it's individualized. If you've got an elderly person who lives alone, you might not want such tight control because you don't want them to be hypoing all the time. So you do individualize it, definitely, but that's the gold standard. Agree with all that? No idea how I'm doing for time. How are we going for time? All right? Pardon? Oh, we're doing all right then, aren't we? Okay, thank you. Okay, so who does know about the changes to NDSS? Well, not many people. No. From the 1st of July this year, there are changes to the NDSS. So what is going to happen is people with type 2 diabetes who are not on insulin will be eligible for the first 6 months from diagnosis of subsidised strips, and after that they won't have subsidised strips until they go onto insulin. I know. So, that's going to be the change. It has been said that people who are not on insulin do not need to check their blood glucose levels. And that's why the government have taken away that funding. That's also a change to PBS, so you won't be able to get them on PBS either after the 6 months. They have to pay full fee. The other change is that the pharmacies will now stock everything. So you won't get them from Diabetes Australia Victoria, you'll actually get them directly from the pharmacy. So it might be worth telling your clients to go along to the pharmacy and get as many strips as they can before the 1st of July. And to actually get to know their pharmacist, because they will be organising it. Is that right? So we know that monitoring blood glucose levels is actually an important part of looking after someone with diabetes. It actually gets them to buy into their disease. It actually gets them to be able to see how they're going and to see the impact food has on them and exercise has on them and what's going on. This is the AccuCheck 360 view tool. Have you all seen this? I love it. I use it all the time in my practice because people don't always check blood glucose levels at times that are actually telling you anything. You get the clients that come in and they check their blood glucose every morning, but no other time. You get the client that tells you, I've checked it at 4 o'clock, and you say, was that to do with food? Was that not to do with food? And they say, oh, I don't know, I just decided to check it. But it doesn't really tell you anything. I get my clients to do this for 3 days before they come and see me, or they go and see their endo or their GP, because it gives us patterns and trends. Now, obviously, if I've got someone who's just on diet control, I'm not going to get them to check 7 times a day, but I might get them to check before breakfast, before lunch, and before dinner, because that will give me an idea of what's going on. But someone who's on quite a lot of medication or on insulin, I will get them to do this. Now, they don't always check 7 times a day, let me tell you. But if you ask them to, you might get 5 times. But it gives you a lot of information. On the back, you get them to write down what they've eaten, and that gives you an idea of where things are going. So HbA1c just tells you really if you're running high. But structured blood glucose monitoring tells you the impact of meals, the impact of physical activity, the impact of stress, whether the medications are working or not, whether you're having hypoglycemia, whether you're having a high, and what your postprandial glucose levels are like. So there's a lot more information collected with that, isn't there? So if it tests at the right time, in the right situation, and the right frequency, you're going to get a lot more information than if you just get a HbA1c. Would you agree? Okay. So this is one that's been filled out, and you can see that you get a lot of information here. And you also write at the top the size of the meal, the activity level, the time that the blood glucose has been taken, and then you get them to graph it. So if we look at this one, you can see that you've got some lows and some highs. That's important information, isn't it? Because the HbA1c isn't going to tell you that. If you look at this, it's low every morning before breakfast. So you don't want that, do you? You want to do something about the treatment for that. That might mean they're running low all night long, and you might need to reduce some of the medication. But the HbA1c isn't going to tell you that. And then this tells you that after lunch, they're going high, and after dinner, they're going high. So you might want to have a conversation. Go and see the dietitian. Let's have a look at the food that you're eating. Let's have a look at the carbohydrate and the portion size. Are you eating low GI or high GI? You need to have a conversation and see what's happening. So it gives you a lot of information, doesn't it? Agree? I think I missed a slide. Let's go back and see what that slide says. So it helps you see the impact of meals, the size and the composition, how exercise impacts. So with exercise, the blood glucose levels can go down, they can go up. and then come down. Checking the blood glucose will tell you what the exercise is doing and can actually help your clients see how well exercise helps bring the blood glucose levels down. So they might be more inclined to do exercise when they can see the benefits. Would you agree? It can also tell you the effect of the medication. So are the medications working? Do we need to start medications? Do we need to change the medications? Are they working too well? Do we need to reduce them a bit? And it's good for the client because they can actually see the patterns and the trends themselves. And when you sit down with them, they'll say, oh yeah, I had a high. I went to a Chinese restaurant last night. Yeah, I can see that. And you chat to them and you can find out a lot of information. It's a bit like being a detective, but it's really good. So we've done this one. So there've been, it was clinically demonstrated in the Australian Step It Up study that this actually helped reduce HbA1c significantly when you had blood glucose level monitoring, because people could actually see the effect, so they were more likely to change things and do things. It's really important. It helps you to visualize it, and it engages clients. Would you agree that clients get engaged when they check a blood glucose have you seen that yourselves? Yeah. When you tell someone to eat something, they might not take any notice of you. But if they check their blood glucose 2 hours later and they can see that a pizza makes it elevated, but eating something healthy doesn't make it elevated, you'll get them to buy into their diabetes management. Would you agree? Yeah. Okay. Now talk about insulin. So as we said here, who needs insulin injections? So all people with type 1 diabetes need insulin injections. People with type 2 diabetes, do they need insulin injections? Eventually. It's a progressive disease. The beta cell function is progressively declining. They will eventually need insulin. They might need to go briefly onto insulin when they have an infection or a severe illness. So when they're in hospital or something, they might go on insulin, but when they come home, they can come off again. Same with surgery. If they have surgery, they might need a short, sharp shock and then come off. Cortisone treatment. So you see that in general practice, don't you, that people who go on cortisone, they will elevate their blood glucose levels while they're on cortisone. So quite often they're going to need insulin to manage that, and when they stop the cortisone, they stop the insulin. And with pregnancy. So ladies with gestational diabetes, about 50% of them will end up going on to insulin as well. Have you found that yourselves? You're all too busy eating now, aren't you? You don't care what I say. Okay, so we're going to have a little look at a case study. So this is you. So I'll introduce Sonia.
Okay, so now what we're going to do is look a little bit about, explore the role, I guess, of a dietitian as a part of the diabetes care team for a case study. So we have a 56-year-old male with a BMI of 28. He's had type 2 diabetes for 7 years. He's quite sedentary. He has an office job, eats out most nights of the week. He's a moderate drinker and enjoys social drinks on the weekend with friends. Really minimal physical activity. And some of his comorbidities include high cholesterol and high blood pressure. So quite representative of, I guess, many clients we see in our practice. So Adam's presented and his HbA1c is elevated and his specialist would like to commence on insulin. So as a dietitian, quite often we refer these clients and they may have never seen a dietitian before in their duration of diabetes, and in Adam's case, he had never seen a dietitian at all. So in these scenarios, we often find that the knowledge of the basics can be really poor in many situations. So when I'm talking about knowledge of the basics, knowing what foods actually impact on blood glucose levels. So Maggie mentioned a little bit earlier with the 360 tool that people can actually circle different size meals. But what is also really important as part of that is that they're looking at the carbohydrate quantity of some of those meals. For example, someone can have a huge plate of steak and salad, and it may have minimal effect on their blood glucose levels compared to an entree-sized bowl of pasta. So we often find that knowledge of the basics is something that we can't assume with our patients with diabetes. And the first question I usually ask all my clients basically is, what is a carbohydrate? Do you know what foods contain carbohydrate? And it's extremely interesting what foods people are missing in terms of those that contain carbohydrate, and we'll go through that in a minute. Looking as a dietitian, it's really important that with our clients we look at their insulin profile if they are commencing on insulin. So the carbohydrate prescription of a dietitian for their client and recommendations can be very different depending on the type of insulin regime they're starting on, and I'll touch on that in a minute. Obviously, glycemic index is really important to look at, and hypoglycemia management. Even our clients that may have been on a sulfonylurea medication and at risk of hypoglycemia, quite often they forget about treating a hypo. And then we have other clients that have diabetes that may not be on any medication, and I'm sure that you see them in your practices, that carry around their little jelly beans in their back pocket in case they have a hypo. So those are the things we need to clarify as dietitians as well with our clients. So when we talk about knowledge of the basics, I just mentioned this a little bit earlier, and we're hoping to have a more hands-on practical workshop today, but we were unable to, just with space and things like that. But the first question I mentioned is to my client, I asked them, do they know what a carbohydrate is? And do they know what carbohydrates do to blood glucose levels? So anytime someone eats some carbohydrate food, it will break down to glucose and elevate blood glucose levels. And that is if it's a high GI carbohydrate food or if it's a low GI carbohydrate food, it doesn't really matter. So if we take a look at the screen now, you can see a wide range of different foods. Which foods do we think up here contain carbohydrate? Does anyone want to call out a few? Fruits, yeah. Yeah. Biscuits, yeah. What else? Yep. Dairy? Yeah. What about the coconut milk? Would it contain carbohydrate? And have some, yeah. Baked beans? Yeah. So all your beans and legumes contain carbohydrate. What about almonds? They're a tricky one. So with nuts, it really depends on the quantity of nuts that someone's eating. So if they have a small handful of nuts, it won't really contain enough to have a marked effect on blood glucose levels. But if someone sits down and eats half a bag of almonds or peanuts or cashews, it'll certainly impact on blood glucose levels. What about, we've got some salmon here. Would that contain carbs? No, so protein-based foods won't. What about the broccoli? No. So when it comes to vegetables, it's mainly those starch and semi-starch-based vegetables that can impact on blood glucose levels. So things like potato, sweet potato, corn, we've got peas over here, and also some of those semi-starch vegetables that not many people think about. So things like pumpkin, beetroot, carrots, they can certainly have some impact on the blood glucose level, but it does depend on the quantity that they're having at the time. So if someone's snacking on one carrot, it won't really have a marked effect on their level, but if they're having a bowl of carrot soup or pumpkin and carrot soup, it will definitely impact on their blood glucose levels. Rices, obviously, and with our dairy foods, it's all dairy except cheese and cream that really contain carbohydrates. Quite often when clients come to see me in regards to fruit, they don't know that all fruits contain carbohydrates and will impact on the blood glucose levels. They often focus on things like bananas and forget that other fruits will as well have an impact on their levels. So for Adam, he has been prescribed some insulin. So he's going to commence on a mixed insulin. And in this instance, as I mentioned, the dietitian would have to tailor the carbohydrate regime for Adam. And in this instance, we would tend to teach Adam how to count the carbohydrates across the day using a strategy called a carbohydrate exchange. So a carbohydrate exchange is the amount of food that contains 15 grams of carbohydrate. And why we would teach that is because actually Adam's on just a basal insulin, so he's just commencing on some Lantus, and we would teach that carbohydrate exchange for that reason. We would also teach a carbohydrate exchange if Adam was commencing on a mixed insulin as well. If Adam was commencing on a basal bolus regime, which we are seeing happen more for our clients with type 2 diabetes, we may teach him another concept called counting carbohydrates in grams. And that's a strategy we also use in our service for clients with type 1 diabetes, whether they're on pen injections or those clients commencing on an insulin pump. So this just shows you an example of what a carbohydrate exchange is. So it's like a slice of bread or half a cup of pasta, 2 to 4 dry biscuits or a small potato. So those equivalent foods have 15 grams of carbohydrate, similar to a small apple, a muesli bar or half a cup of breakfast cereal. So in our clinic, working with the dietitian closely, we teach our clients how to count, how to identify a carbohydrate exchange in their meals across the day. And then we give them targets to aim for so we can get that consistency there across the day. So for example, many of my clients may have, say, 2 exchanges of carbohydrate for breakfast, and it might be 3 at lunch and dinner. And if they have a snack in between, we ask them to have up to that sort of 1 exchange if they do. And that helps keep their blood glucose levels more consistent across the day. So looking at this meal, which one do we think would contain more carbohydrate? Would it be our toast and a glass of juice? Or would it be a bowl of muesli and a cup of milk coffee with it? Anyone want to have a go? Okay, let's have a look. So when we teach our clients, we would have 4 exchanges here in this meal. So each piece of toast would be 1 exchange, and there'd be 2 exchanges in that glass of juice. Then we look at the muesli. We've actually got up to 7 exchanges there. With the muesli, it's quite a large bowl. We would also have the dairy on that and the milk coffees. And it's alarming that with many of our clients having large lattes, cappuccinos across the day, they actually have to count those as carbohydrate, and many aren't. And that's where we often find that if they have that and something to eat at morning tea, they go into lunch quite elevated because they haven't been counting that carbohydrate across the day. Another one, we've got some sushi, so some Californian rolls, 3 of those, compared to a pita wrap for lunch. Which one would contain more carbohydrate? Sushi. So we've got 6 exchanges there. So each Californian roll has the equivalent carbohydrate to about 2 slices of bread. So many people miss that. It's actually very high and very dense in carbohydrate with all that rice packed in there. Compared to our pita wrap, which is often also underestimated, but that can be up to 4 exchanges per meal. And just with here we have a dinner of steak, potato and some salad and pasta. This is a bit of an easy one. Does anyone want to have a guess at how many exchanges the pasta might have? 8? We've got 2 just with our potato there. So quite only a very small potato, or about a bit smaller than my fist, is 1 exchange of potato. So that's a large potato at 2 exchanges. The pasta's up to 6 exchanges. So if someone eats out, they're going to have at least 3 to 4 cups of pasta in a main meal pasta dish. And for us, we teach our clients about a cup of pasta is 2 exchanges, so it can quickly add up for those meals. So baseline, as a dietitian in our practice, we individualise these exchange targets. A good dietitian that's worked in diabetes will know how to individualise this with their clients. So these are, I guess, averages on what we tend to start with, but most of our females will start with our target of about 2 to 3 exchanges per meal. If we've got males that are quite active, that aren't as sedentary, we may increase that up to 3 or 4 exchanges per meal. But then we have younger clients now that have type 2 diabetes a lot earlier, and they may be active, they may be doing sport, triathlons, those sorts of things, and their targets could be about 5 exchanges per meal. So it really needs to be individualised for them. Generally 1 to 2 exchanges for snacks at the most. The 2 exchanges is really for those women with gestational diabetes. And we do, I guess, teach a lot of these concepts with that group as well. And with our GDM women, snacks are so important across the day to not only ensure that their blood glucose levels are regulated, but to ensure that they achieve nutritional adequacy for mum and bub. We look at the peak insulin action time, and we obviously take into account their activity. So GI is also extremely important, but we can't, I always say carbohydrate quantity number 1, GI number 2. We've had so many people diagnosed with type 2 diabetes in the 80s and 90s where GI has just been drilled into them, but they don't have a concept of quantity of carbohydrate. So we always start with getting their head around quantity of carbohydrate first, and then really encouraging that low GI eating. We still have the best evidence around quantifying carbohydrates and low GI eating for our clients. Do any of you use our resource here in practice? So this is a really good summary of GI for your clients. These fact sheets can be uploaded from the Baker IDI website, and they're free to use. And there's also many other fact sheets that you may find useful in your general practice work. Other things we need to consider: weight management, obviously, dietary fats, label reading, eating out, shopping. We have a fantastic shopping guide that we update every 6 months at Baker IDI. That's also on the website. So if you have clients that just are really struggling at knowing what to choose at the supermarket, it can be a really good guide to get them going, to get them identifying better products for them to be choosing. I'm going to hand back to Maggie now to finish the presentation.
Okay, I've got 10 minutes to talk about communication, so that's good, isn't it? So basically, we all know that you need to communicate, because if you don't tell each other what's going on, it's a little bit like you've got to be telepathic, and I find my telepathy doesn't work particularly well. So it's really important that we do communicate, and it's in the RACDP standards, as you probably all know, for accreditation. It says that we've all got to be able to communicate, that our referrals should identify who the patient is, who they're being referred to, and actually give some information to the person you're referring to about what the hell it is you want them to do. Not just sent this patient to you, which, isn't that good. The feedback is also important. So the feedback from the person you're referred to, they need to actually tell you what they've done. So there's no point you sending someone to me and then me saying, oh yeah, saw them. It's about talking to each other and actually helping the client. Because after all, it's all about the client in the end, isn't it? So the more information that you can have between us is better for the client. So also for community health professionals too, to feedback. So it's two-way communication. And I know I deal with some specialists who always send me information that tells me the patient's name, tells me when the patient was diagnosed with diabetes, tells me what medication they're on, what their latest HbA1c was, what the cholesterol was, etc., and what they've been up to. And then I get others that just say, can you see them for diabetes education? You can imagine which specialist I prefer. Same thing, I know that if I write a letter back telling them what I've done, they're more likely to refer back to me because they know what's going on, instead of me just saying, I've educated this client. So communication's really important. You guys, the practice nurses, you are the main point because you're there all the time and you see the clients all the time. So you can build up a rapport with your clients and get to know them. Some of my clients I might see once every 6 months. You guys are more likely to see them because you do flu shots and you do all sorts of things, wound care and things like that. So you see your clients all the time. Would you agree? I mean, I don't mean you see all of the clients all the time. You couldn't possibly. But you do see some of the clients regularly and get to know them, don't you? So you're in a really good position to be able to do stuff. So you will be able to identify when a client needs to be referred on. And then you can say, I'm going to refer this client on to a podiatrist or a dietitian or a diabetes educator or a physio or somebody else, yeah? Would you agree it's usually you that identifies it? Yeah, okay. So really important. The Australian College of Nursing discussed the role of practice nurse to include integrating service delivery, including managing internal and external referral processes, arranging case conferences. Do you do case conferences? No, I don't see it much at all, but you do? Oh, I thought you said you did. Sorry, I thought you were saying yes, I do. and planning and coordinating care. So would you guys agree you do the planning and coordinating? Yeah. Okay. So really important to get that communication happening, that two-way communication, yeah? Okay, so this is another case study. This is Michael, good-looking guy. Michael looks really good, I think, for 64. So he's got a BMI of 30.3. He's had type 2 diabetes for 18 years. HbA1c 9.6. Are we happy with that? That's a little bit high, isn't it? Total cholesterol 6.2. Are we happy with that? Nah. HDL 0.6. Nah. LDL of 3. Triglycerides 2.5. Blood glucose levels 14 to 17. And blood pressure of 140 on 80. Not too bad. All right. So it's on diaformin 1 gram BD, so it's on optimal therapy there. It's on diamicron MR 120 milligrams daily, optimal therapy there. It's on Forxiga. Doesn't do exercise and he's never seen a dietitian. The referral that came through is from the GP, says, thanks for seeing Michael. So it really tells you a lot. You've got no idea where you are, what you're seeing Michael for. So what should have been referred? Same thing. All that information that we just said, that should go to the person you're referring to, but also tell you that they've been referred to a diabetes educator and to a dietitian, so that you know you don't have to try and cover food as well, or talk them into going to a dietitian, and so the dietitian knows that all that other stuff has been covered. Really important. So this is the consult notes that I've made, so I've seen him and I've done all these things. I've written myself some lovely notes. But then I've sent a letter to the GP saying, thanks, he's been seen, that's it. So that's not really useful either, is it? Really need a little bit more information. So what I should have sent back is all the things that I did and my plan. So what's the ongoing management from my point of view that I'm doing with my client? Do you agree? See, I got through that quick, didn't I? So, really important to have that two-way communication so that everybody's on board and it actually gets the client to feel like they've been listened to. So if you've said to the client, I'm going to send a letter back to the GP and tell him what we've discussed, they're more likely to go back to the GP and see the GP. And when the client comes to see me and they say, oh, didn't the GP tell you that? They get a bit annoyed that I don't know why they've come. It's really important for the referral to me or other people to actually say what you want. Because my telepathy isn't good and neither is yours. But communication is really important. Thank you.